Good morning and welcome to the 27th meeting in 2014 of the Health and Sport Committee. I would ask everyone who is in the room to switch off mobile phones as sometimes they can interfere with the sound system, although in saying that you will notice that committee members and indeed some of the clerks are using the tablets instead of the hard copies of their papers. Our first item on the agenda today is a decision on whether to take consideration of our draft budget report on the Scottish Government's draft budget in 2015-16 in private at future meetings. Is the committee agreed? Yes. Thank you. Agenda item number 2 is subordinate legislation. We have 2 negative instruments before us this morning. The first instrument is Scotland Act 1998, Agency Arrangements Specification Order 2014 S1 SI, sorry, that's because it's a, right, SI 1892. There has been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on the instrument. Are there any comments from members? No. Is then the committee agreed to make no recommendations? Yeah. Thank you. The second instrument is Food Hygiene, Official Feed and Food Control, Scotland Amendment Regulation 2014 SSI 2014213. There had been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on the instrument. Are there any comments from members? No. There will be no comments as the committee agreed to make no recommendations. Sí. Thank you. Agenda item number 3 is, of course, our draft budget scrutiny. This is the first this morning, and we begin with our witnesses before us this morning. Dr. Andrew Walker, University of Glasgow, welcome. Professor David Bell, University of Stirling, welcome to you this morning. I don't know whether we're going right to questions, or do you wish to make some points, Professor Bell? Thank you.
Yes, I was going to make a few introductory points, if I may.
Yes, sir.
Can I just start off with the share of the budget? So, how much does health spending account for as a share of the Scottish budget? Which is an issue of some interest. And actually, for 15-16 compared with 14-15, the share appears to drop from 33.8% in 14-15 to 32.5% in 15-16. But that is somewhat misleading. In fact, the share stays pretty much the same if you discount the AME spending on the Scottish pensions provision. So there's been a huge increase in the budget, AME budget for pensions, which apparently results in a reduction in the share of health spending, but that's actually to do with something that's not really under the control of the Scottish Government. Can I also talk a little bit about spend per head in Scotland? So between 2008-9 and 2012-13, health spending in Scotland compared with that in England has gone from a higher spend in Scotland with a margin of 14.3% down to one of 11.7%. So there has been something of a fall in the relative spend in Scotland compared with England. At the same time, there hasn't been a huge amount of change in Scotland's overall extra spending. So in 2008-9, Scotland's overall public expenditure per head, the margin was 18%, considerably more than the margin in health spending. And in 2012-13, it was 19%, so it hasn't changed that much. But there has been a bit of a change in respect of health spending. Happy to take questions on that. Could I just also say a little bit about targets? I think Andrew has commented on targets in his piece, so I'll be brief. I mean, I consider targets just to be a sort of one snapshot of experience, and what people are interested in is the broader perspective of the health service and their experience through the health service, what kind of care they're getting, what quality, what availability, and perhaps would like to see more broader public involvement in the issue of how we come to decisions around what it is that we want from the health service. Interesting, the Scottish Universities Innovation Project is doing something on well-being at the moment, doing a project on well-being. And we're looking at how we might engage the public in the national performance framework to a greater extent than has been the case up to now. As an economist, what I try to do when thinking about things like what's the level of productivity in the Scottish Health Service, I look at the Information Services Division statistics. It is quite difficult to figure out what really is happening with productivity in the Scottish Health Service, and how, for example, are costs changing, and so whether the GDP deflator, which is used by publications, not only in Scotland, but the SPICE publications use the GDP deflator to get to what they would describe as real spending in the health service, whether that's the appropriate measure of costs in the health service. It's not entirely clear to me that there is sufficient evidence to back that issue up in Scotland. Something on social care and health, the mix or the interaction between social care and health. It seems to me we're in for a long and extended period where local government budgets are going to come under increasing pressure, and where health budgets are likely to be protected to some extent, or to a greater extent than local government budgets, and that will put more and more pressure on the interface between social care and health care. So it is important to make as efficient, as well evidenced as possible, the use of resources that go to the interface between these two areas. A final point, and one which is perhaps from left field a little bit. I noticed that the See Me campaign today has produced a document asking for an end to the stigma around mental health. It does seem to me that maybe Scotland is a little bit behind the curve in terms of its focus on mental health, not just in relation to stigma, not just in relation to well-being, because it is clear, the evidence is absolutely clear that mental health is one of the most significant predictors of low levels of well-being, but also of the economic case for investment in mental health, which has been made quite strongly south of the border, where NICE have recommended a number of policies in relation to a switch towards mental health. And now that the Scottish government has control over at least a proportion, perhaps an increasing proportion of its income tax revenues, there's a case for looking at whether, for example, investment in more mental health capacity within Scotland would lead to a larger increase in income tax revenues than would, say, an increased investment in childcare, which is which is a proposal that seems to be out there. Anyway, that's a set of points I thought I might make, ending on a slightly controversial last point.
Thank you. Doctor, what do we have? Written Evans, do you want to make a few...
Briefly, please,
yes,
Convener.
Certainly.
Thank you.
Yes.
Thank you, and thank you for inviting me. Having been advisor and witness, I think the only role left to me is to get elected and be a committee member as well, but I tell you, I have no ambitions in that direction whatsoever, lacking so many of the skills and talents that the committee exhibits. Listening to two economists for an hour, you're very brave people. I think having read draft budget documents since 2001 as part of my role with the committee in the past, I think I see a lot of continuity here in terms of the style and presentation of the document, and that continues to frustrate me. I don't think it's specific to this document. It's in common with all documents. It's essentially an allocation statement where we take a top-level line in the budget, roughly £12 billion, and say which lines in level 2 and level 3 of the budget it's going to go into. There is some accompanying text which is loosely linked to the budget but isn't always clear what line it feeds into, and having seen the SPICE briefing that became available yesterday afternoon, I can see some more of those links, but it continues to be a frustration that the text in the document doesn't really tie in with the tables terribly well. I think the committee's questions that they sent out this year in terms of the National Performance Framework was helpful to remind us that that was there, but it does kind of highlight the fact that, again, they don't really link into the draft budget document. Certainly, the mention of national outcomes is there at the start, but in terms of specific indicators, there isn't much analysis of what's going well, what's going less well, and whether budget spending should be allocated in line with that. And I think that's an issue we might come back to. As I looked across the different indicators, some are improving, some are staying the same, some are going in the wrong direction. I think the two that caught my eye probably were some of the public health ones that are staying static, and the possibility the committee might like to pursue the line of why is apparently there no progress on improving levels of physical exercise and smoking cessation in Scotland. Both things we'd like to see improving, but according to the indicators are currently stalled. And is there a case for more government spending to be put behind moving those in the right direction? The main other line I commented on, given my sort of role in the area, it was the New Medicines Fund. And just to remind the committee that I do have conflicts of interest in here as I do work with pharmaceutical companies. But, I think the New Medicines Fund clearly responded to the debate you had in Parliament and the cross-party consensus that came out last year on better access to medicines. I think we can see, put in the historical context of about £10 million per year extra going into prescribing costs, the fact that the fund stands at 40 million shows what a difference that decision did make and will make. But there are still questions about whether that's the right sum of money, how the Scottish Government plans to stop medicines sort of accumulating in that fund and it building up, and next year we need 80 million to go into it and the year after we need 120 million and so on, and also bringing it back to the issue of health gain and how much are we getting for this money. So I hope I've gone into those in a bit more detail in the paper. As I read through, I did notice I had a section 1 and 2 section 3s. So having exhibited the inability to count to 3, I'm happy to leave at this point, should the committee wish me to, Convener. Otherwise, happy to take questions.
Thank you. Thank you both for those introductory remarks. Richard Simpson, I think you've got a first question.
Yeah, it's really a general question to open with, and that is not just the Christie Commission, but really since 2001. Dr. Walker, since you were involved with us and I was on the committee at that time, we have talked about a shift in the balance of care from the acute sector to preventive, and that this was fundamental to ensuring that we had a sustainable health service. Do you see anything in this budget which actually evidences a coherent attempt to make that shift, given the additional impotence of Christie, which was absolutely clear that we were going to fail if we don't get this right? Is there any evidence in this budget that's going to happen? I mean, I know it's, some of it has to be level 4, it has to be the health boards, but really, unless there's a central drive for it from the Parliament, from the government, from this committee, we're playing at it, I think. So, I wonder if you'd just like to broaden a little bit on that.
Absolutely, and knowing Professor Simpson before 2001, we'll know that for the decade before that we were talking about it as well. So this has been an extremely long-running theme. I think the best answer to the question that I can see in the document is probably the integration fund and the assumption that because it will be linked to local government spending, that it will be community-based services and therefore place the emphasis on getting people out of hospital. That's the clearest thing I see. But as you suggest with your question, some of this has to be implied, and I'm glad that the committee will come back and ask more questions in April when they see Health Board's delivery plans. I agree that there needs to be a central commitment. I guess in the Scottish Government's defence, £70 million is quite a big chunk of what was available to put into that. I guess we would all feel a little more comfortable if there was a firmer commitment to what we will see in 12 and 24 months as a result of that, in terms of something maybe measurable. But that, I think, is the best we can do with the draft budget at the moment. I don't know, David.
I actually looked at some data from the ISD website. I did manage to find some on activity measures, and it is quite surprising, it seems to me, how rapidly acute speciality throughput has been increasing over the last 6 years. So you take 2008 to 2014, inpatient stroke day case discharges have been growing annually at 2.1%. Whereas, day case discharges at 1.9%, A&E has been increasing at 0.7%, and consultation with GPs has been increasing at 0.3%. So the way it looks to me is that actually acute throughput has been increasing faster than has, say, GP consultations and so on. So, in fact, the case may well be being made that the reverse of where the government has been trying to go should be the one that's being followed. I'm not saying that I agree with that, but it clearly, somehow or other, the system does seem to be focusing on the acute side rather than on the on other activity.
Just as a supplement, if we take the section of the budget, improving health and better public health, there's an increase of 1.3% this year. But if you strip out Family Nurse Partnership, which we're all supportive of, it's a very interesting programme, but it's hugely expensive. I mean, it is inordinately expensive. I mean, if I said to one of my nursing colleagues when I was a GP, we're going to give you a workload of 20 patients, and if they drop out, you won't have to replace them, they'd have bitten my hand off for that job. Bitten my hand off. Because, it's not that it's not intense work with these families, but, 20 as a caseload is just extraordinary. And if you strip that out, everything else is going down. I mean, the food and health budget, we've got a huge problem with obesity. Food and health budget down by 48%. The grants to voluntary bodies, which are critical to delivery of many of the public health issues, down by 13%. Healthy working lives, static. I just wonder if that section of the budget, the whole thing about health improvement and health inequalities, is, are we really, is this appropriate? Are we, I know some of it's shifting and we've got to actually tease that out because the Keep Well thing is being put into the health board and they're being told just to get on with it now. But there's no evidence that the Keep Well thing is actually working. So anyway, would you like to comment on that section of the budget? Because
Absolutely.
That's the only identified preventive spend that we've
No,
got.
you're right. You're right.
And there's
you're right.
tobacco and alcohol. Alcohol's down another year, despite being a major problem. Tobacco's been flat for 4 years now. Tobacco cessation.
Yep.
These are the big public health issues that, and obesity being the other one.
I think absolutely. I think I said in my written evidence, I think there is a question about if we could have put £70 million into an integration fund or a public health fund. I can see that there is a case for both of them. I think my instinct would have been towards the public health fund to tackle inequalities directly. I don't know what that would have done to health board finances. So I guess that poses a choice for us all, though, about whether we're talking about moving money from acute into primary care or from curative care into preventative care. So the public health one would push us more towards the latter one, the prevention of ill health before it happens. And the integration fund would push us more towards when people are sick, where are we going to care for them? So I would distinguish those two, but I would certainly like to hear those cases more clearly argued and understand on what basis Scottish Government decided to bet the budget on the integration fund. I think that's the key issue from this draft budget.
Yeah, I mean, I agree in the sense that what's missing here is the information that we need to clearly make the kind of decision that you're implicitly referring to. The family nurse partnerships thing. There is quite a lot of evidence of that both public sector costs and tax revenues are very skewed towards the real problem parts of society. And then the question is, maybe even a caseload of 20 would, in the long run, if you take if you take everything into account, it would still be value for money. It wouldn't necessarily be best value for money, because you might have alternatives that would give you a better rate of return. But what we don't yet really seem to have is the case that helps us make that kind of decision.
I want to make it clear, Convener, I'm not against the family nurse partnership. We're all committed to it. I think it's a valuable thing that's been proven in America to be functional. But given that you have to make choices in budgets, there's, it's a really difficult one to know whether we should be expanding that as rapidly as we are because of the costs involved.
Doris?
Thanks, Convener. I think Dr Simpson started with a really important line of questioning. Every year we get to a stage where, actually right at the start, we say, are these the budget lines we should be looking at? Or should we wait till health boards set their budgets, and is that the real scrutiny? So my reading of this is that the political commitment is passing on Barnett consequentials to territorial health boards for direct patient services. I think SPICE shows it's a 1.1% real terms increase in relation to that. But more importantly, I think what we're trying to do as a committee is, rather than looking at those numbers, which take the politics all out of it completely, it's how we spend the monies. And I'm just wondering if this is a transition budget, because we've moved to health and social care integration, and what I've no idea about is when I look at the draft budget for 2015-16 and I see £9.474 billion going to NHS and special health boards in revenue, resource allocation, is what chunk of that will find its way into the first health and social care local delivery plans across all 32 local authorities, and then what those priorities are. So I don't know if this budget process in part is a little bit of shadow boxing for the real scrutiny that has to come ahead, and that in years to come, whether or not the real robust scrutiny we need is to look at those health and social care plans at a local level. This is still a very important scrutiny, but other than debating about headline figures, and I think Richard Simpson made an excellent point about the family nurse partnerships, but what I would say is governments are accused of not thinking long term. and because it's very costly up front and you don't get the benefits for a generation or so, family nurse partnerships are one of those actual initiatives where it doesn't bear fruit for a number of years. So that's the bind politicians find themselves in. So I know I'm drifting in my question, and my apologies, convener, for that. I suppose I'm asking is, I'm looking for a steer, actually, quite frankly. It's for the politicians to do the scrutiny, but you guys are economists and health economists. Is where is the real detailed scrutiny that we have to do as a committee? Do we look at these headline numbers and how they relate to national performance frameworks and outcomes and targets and all that? Or do we already start turning towards health and social care integration, which seems to be the real biggie at the moment?
I mean, I think the health and social care issue is critical because of the demographic change we're going to see over the next couple of decades. And we've got budgets, as I mentioned earlier, that are probably going to go in slightly different directions, in the sense that health is most likely to be to continue to at least be stable in real terms, although we know that if current age profile of spending doesn't change, then actually it should be increasing in real terms just to stand still in terms of giving the same level of care to older people, for example, as they're currently receiving. And then on the other hand, you've got local government. The local government budget, which has already come under a lot of pressure, is likely to continue to come under pressure because it's unlikely that we can foresee a situation where there will be any substantial increase in overall spending. Indeed, it's likely that overall public spending will continue to contract for the next 3 or 4 or possibly longer years. So you've got these two organisations that are being funded, whose funding profile looks a bit different, who are being asked to integrate and produce some new joined up provision, and it seems to me that that's going to be a critical aspect of the success of Scottish Government policy, because it covers the two areas. It's a cross-cutting issue. It's not the success of the health budget. It's not the success of local government. It's these two together, and it seems to me that there is an argument for looking at those in particular detail, and that would be a more useful exercise than the kind of exercise that we're going through now. But going back to what Dr. Simpson said, the issue of preventative spend is also very important in these areas. It may be over a shorter time period, but how do we deal with older people to ensure that they don't end up with needing acute care for prolonged periods of time and so on? That seems to me to be an issue of great importance for the committee.
I think from my point of view, I completely echo what you're saying, Vice Convener, that the 80% of this is just going to the health boards, and we can't see that. And I'm very glad that the committee comes and does its scrutiny in April, because it's the only effective scrutiny I think that the health boards get of that. I think on top of that, as we all know, about 98% of it gets spent on the same things as we spent it on last year. So we end up talking about quite small changes around the margin in the context of a portfolio that's controlling 1/3 of the Scottish Government's budget, and organisations within that, like NHS Greater Glasgow and Clyde, which have budgets bigger than some portfolios that will receive parliamentary scrutiny. So that the whole thing does get a bit skewed around. I think some lines in here are very important and interesting, and it certainly merits some of the committee's time to look at those. I think the key debate is the one that Richard started, integration, public health, new medicines. Where's the balance? Given that those are all three things that we would like to spend money on, Where is the balance between those? I think that's a really important thing to look at this stage. I think the amount of time the committee devotes to looking at the health boards and presumably this year to the health and social care partnerships, as you say, is appropriate. But if I cut back a little bit on the time you spent scrutinising the national budget at this stage, I might devote it a little more to the performance framework and the number of targets and indicators there are. Because, as I did my background work for the committee meeting, I found the National Performance Framework, various iterations of the data. I found a website called Scotland Performs, which may or may not be the same thing. I found the heat targets that we know about from the NHS. And reading the SPICE briefing, I found out about a thing called the Quality Monitoring Framework. And I'm not sure whether these are all overlapping, whether they're intended to overlap or integrate. And I think maybe the committee spending a meeting or two just getting to the bottom of that and maybe encouraging Scottish Government to demonstrate to those outside of Scottish Government how these link together and make them a little bit more transparent would be time well spent.
Okay, I think that does take you somewhere with our scrutiny. You mentioned the integration fund, you mentioned the new medicines fund. Now in the year coming up, that amounts to about £111 million if you add those numbers together. A significant amount of cash, but still, I suppose, in the greater scheme of things, a relatively small chunk to that headline figure that territorial health boards get, although I take on board the point you're making, a lot of those costs are fixed, so the room for manoeuvre there. Would one of the main rooms for manoeuvre be, as I think you've suggested and Dr Simpson suggested, reviewing the targets that the territorial health boards have to meet, whether that is in terms of surgical procedures and inpatient and outpatient waiting times, and can in any review of that would surely have to be twofold. It would have to be looked to see what patients are looking for outcomes for the NHS. In other words, does 18 weeks make a significant difference to someone for a hip replacement compared to 16 weeks? And I just use those numbers off the top of my head. But if it didn't make a significant difference, can you monetarise the cash saving to have that extended time and therefore the cash release to then put the money somewhere else? And then you could only obviously do that if there was patient support, because it's a national health service for the people that we all represent. So yes, we can do the consultation with patients groups and the NHS and our communities and constituents and government, and the committee can do that. But I suppose what we need the health economists and economists to do is to monetarise what the cash release savings would be for any decisions that the Scottish Government would take, that we would of course scrutinise, convener, to get cash out of that suite of targets and outcomes if we rearrange them or slim them down, and we have the public support if they know how we're then redirecting that cash. Is there any work on that you could point us to, or is it work you'd be itching to do? Or
to agree with everything you said up until the last statement. Wow. Okay. PhD sort of length piece of work. No, but to come back to the bits, I completely support that. One thing I really welcome that the committee has done in the last 3 or 4 years is step out of this annual scrutiny at this stage and start to look at what the health boards do as well. I think that's a terrific advance, and I think the sort of thing you're proposing, where you look at the targets as well and whether they're set at the right level, whether they cover the right range of things, and I guess also noting things the BMA might say in the second session, how they are actually whether they appropriately drive decision making at local level. I think those would be excellent areas for the committee to have. I would suggest almost as an annual item, and maybe give up some of the time you spend looking at this fairly arid, level 2 and level 3 document at the moment. You asked a specific question about whether I was aware of things that would monetize those targets. The answer is I'm not, and it speaks to the fact that I think both Professor Bell and I have alluded to in our evidence, that we really don't have a lot of the data that we need to help us make decisions. We would like to know, if you set the time to treatment target at 18 weeks versus 16 weeks versus 24 weeks, what's the cost difference of that? Scottish Government might have that information. So what we might be talking about is structuring some questions for Scottish Government to provide the evidence that the committee then considers and scrutinises. I'm not aware of any independent economists working on that, unless Professor Bell is about to surprise me.
I'm not. And to make a nerdy point, and following up on Andrew's last remark there, it may well be the case that not all weeks are equal in terms of cost. So, you know, if making the going from 12 to 18 may cost you X, but if you went per week, but if you went from 12 to 24, it might cost you quite a lot less, because you're not having to put people out to, say, private providers to for the necessary care just to make that particular target. So it's not the average that we're interested in, but it's how much you have to spend right at the margin to hit that target that you're interested in.
Thank you. Just following up on some of that, Bob, I think we've had a bit of a debate about the boards and that scrutiny still to come. But when we look at the recent debate which became public, which was the sort of leaked report of those people who are actually running the service, it isn't simply an allocation, is it? Because they complain bitterly that the introduction of new legislation placing binding financial resources and obligations on NH boards. They complain about policy decisions being made which require boards to prioritise additional investment in acute care, and we have seen that is increasing, in conflict with the 2020 vision. The draft budget, where there's the big messages there, of course, and boards, politicians and governments come in all guises, and you make the point in your submission, Dr. Walker, about the drugs bill that we got caught up in, but there haven't been any real evaluation about, in terms of whether that money is well spent, or indeed the provocative point that Professor Bell made about should we be investing in childcare, early years, or mental health. So there's no real evaluation on that. But I mean, they come to the conclusion that there's a 450 million pound additional savings required to meet some of these, these challenges that have been faced by boards. They all have an impact. It's not just a draft. It's not just a budget allocation. It comes with all sorts of catches and clauses and demands, which are not very open at all. Indeed, these discussions are taking place with government and the health board managers in secret.
I it's a question of a governance. It seems to me, how do we run this system as a whole in a consensual way that everyone understands and accepts? It's a really difficult problem, because politicians often want to interfere. Then there's a question about how democratic are the boards themselves. How do they come to make decisions? What would the public accept as in terms of how far they would like to see politicians interfere with the processes and so on. So, I mean, and given what Dr. Walker said about the different sets of targets that are out there, as a health board manager, it must be a very difficult space to live within.
I echo that, and I think when the committee looks at the health board's plans for next year, there'll be a chance to try and quantify some of those targets. I know you try to quantify the prescribing uplift, etc. Maybe scope for a broader question about please tell us about other cost pressures, because we want to see the evidence base for those. I'm aware, as you are, convener, of the £400 million figure, but obviously don't know the detail of that, how that was arrived at. So that would be interesting to know whether you want to wait and whether the committee wants to wait until April to next year when the board's scrutiny is planned to find that out is another issue. But I think that would be very important to know and to find out the pressure, whether the 3% savings target, to come to one of the 7 questions you asked, whether the 3% savings target that is imposed across the public sector is going to be enough, whether the £400 million figure implies it should maybe be 4 or 5% within the health portfolio, whether just what Scottish Government's reaction is to that figure, whether they accept the figures and agree with them, yes or no. I think these are very important, but my frustration with the budget document, and I think I agree with you on this, is it doesn't give us any of that information at all, and neither has any previous version of it going back to 2001 either, and it's a frustrating business.
I mean, the paper was released to us by the government, and when we asked for it, I mean, it's £100 million in pensions. Changing access to drugs is projected to be 50 million in 2016-17. So they have applied some figures here, and we have a political consensus, of course, on progress or lack of progress on the 2020 vision. But we don't see that political consensus across the Parliament, across the parties, by government itself being reflected in the draft budget in terms of the priorities to push this through. In fact, the contradictions of the case that we're still investing in beds and staff and buildings and hospitals. And
I think, as I look at the Parliament, obviously as a voter, as somebody who comes here and advises and things like that, I think one of the terrific advantages is the cross-party consensus we have on so many aspects of health policy within the Parliament, across parties, and that things are not usually controversial. Most of the fundamentals we agree about. I think what there isn't a consensus on is a sense of priorities. So everyone agrees integration is a good thing, everyone agrees public health and prevention is a good thing, everyone agrees more access to new medicines is a good thing, but what do you do when you can't have all of those 3 things? Which one of those is the most important across parties? And I think that's the part of the debate that's still missing. Everybody quite likes hospitals, but everyone quite likes primary care as well. So when you can't have both, which do you choose? And I think it's that debate that I guess I'm still waiting to happen in Scotland.
okay, Richard Lyle.
Thank you, Convener. I listened intently to Professor Bell and Mr Walker. Can I turn to Mr Walker's comments in the written submission you've given us? And if you bear with me, Convener, I'd like to read into the record some of the points that I've highlighted. You've been reading the draft budget since 2001, doing each year. Another decade-long problem is the lack of any link between planned spending and planned outputs or outcomes, and this stifles debate about the allocation. The debate falls back on sharing the cake, and roughly is in line with last year, a little more or a little less than others. Debate goes on not beyond how great are the pressures and anything like to go seriously wrong before we do anything in 12 months' time again. However, we end up with a pattern of spending that's probably different to the one where we achieve the maximum health gain. And the last paragraph I really like, and this is the point I want to ask you. To repeat, this is not a criticism of the present Cabinet Secretary or the Government, but rather a frustration with the way the Scottish Government and the Scottish Parliament is setting into a pattern of accepting this as a norm. I invite MSPs to reflect on whether we should have a fuller debate. Basically, along the questions that Richard Simpson, Bob Doris and the convener have made, do you feel that we should have a fuller debate on health of all the parties, on the way that we project for the next 10 years, how we're going to make spendings, or should we do, as previously a lot of people have just done, tinker about at the edges?
I think I welcome your question. I think a case can be made for the incremental approach. That essentially you would be getting into some massive issues. Bob Doris asked me a question about sort of spending on various levels of waiting time targets that would be, you could have a guess at, but to do the detailed work might take months, frankly, to come up with the answers to. And you would ask some really fundamental questions. So the alternative is to do the incremental thing, to maintain public confidence in services, but to leave leave a lot of the decision making to local people? Or does Parliament try to become a little bit more interventionist in this and to look for, as I say here, links between the spending and the outcomes? So what is the health of the population? What is the health service going to look like in 5 and 10 years' time as a result of what we're doing today? And at the moment, we've got the 2020 vision, but it doesn't quite link in with the budget document, which stands alone, and that doesn't quite link in with the National Performance Framework, which stands alone. And I'd be very happy to know that some people in Scottish Government have an overview across all these things. Of course, you'd expect the Cabinet Secretary and the Chief Executive to be in that position. But to have it there for outside consumption so that there's an integrated plan, the different parts seem to stand alone. And I guess the paragraph that you read out kind of came from the heart, because it's why I'm not the advisor again this year, because it's been just a frustrating experience of dealing with fairly arid documents that don't really give us the information we need to have the discussions we want to have. And lead to the sorts of issues that the convener led me to a minute ago, where we're not really choosing between different priorities, integration versus public health versus new medicines, because we can do just enough for each of them to keep them going. And I come back, there is a political case for doing that. That might be a perfectly respectable thing to do, but is it the one that's going to give us the best long-term outcomes?
Professor Bell, you made comments away at the start about this has went up, this has went down, all the different figures, All too often political parties batter, and I respect the comments made by Dr Simpson earlier on. Political parties throw at each other, we spent more than you last year and we spent less than you, or whatever, and your targets have went up, your targets have went down. Are we too focused so much on targets that we forget at the end of the day we have one of the best health services in the world? And we have to rationalise in one way that we go along with the staff and the people who work in it in order to help them, and also to help the situation that our demographics are changing with the elderly. We're all getting older. None of us are getting any younger. And basically, in 10 years' time, I may need that situation of to get into the health service, and very seldom I'm in a hospital. I take pride in the fact that my doctor sees me about once every 7 years. But the situation is we are all getting older, so should we nationally, everyone, including yourselves, be looking at the whole situation of the National Health Service in order to make it better for the people of Scotland?
Okay, so I agree with your first point about sometimes the batting about of relatively small numbers is not a terribly useful exercise. It seems to me, a very, very large resource has been put into the health service. Probably at the margin, a small change matters less than how efficient the system as a whole is. And as this debate has exemplified, we're not in a terribly good position to know how efficient the system as a whole is. We do, I think, have a reasonably efficient system, but we also have some very bad health outcomes. So, we still have levels of life expectancy that compare very poorly with other parts of the developed world. So we do a lot in terms of, and we're good at interventions, both in health and in social care. But we still have overall, and we've had not all that much impact in a relative sense on these outcomes since 2001, where we started debating these budgets.
Supplementary to this?
Yes. Just maybe a silly question, but if in 2001 we'd said, right, okay, 3% savings a year have to be made, which we've been doing almost continuously, 1% of those has to be applied to public health, instead of being just going back into every time into either to the government as it was at one point, or back into the health service to be used for the acute service. If we actually directed to that extent centrally, on top of the integration fund, which is, so that would be a separate thing, then, would that be something that would be worthwhile doing, because it's not directing them precisely where it should be used, but they must do it in the most evidence-based, effective way. But if you said you can't just put it back into acute services, you've got to put it, at least 1% of this 3% has got to go in that. Would that be?
I think, as you've illustrated yourself, not everything done under the banner of prevention is cost effective or particularly effective. But nevertheless, I would welcome the point you're making. If we assume that roughly on average the NHS budget in that time was £10 billion, then a 1% saving would be £100 million per year, and I think that would make a substantial difference to some of the public health indicators we've seen. So I would personally very much like to explore that option, being careful what it was actually spent on.
I mean, I agree with Andrew there. I do think we need to educate people and the press about the importance of public health measures, and that the outcome may not, or the beneficial outcomes may take place over decades in the future. And that is often quite a difficult sell.
In the press as well, journalists sometimes draw the distinction between the deserving sick and the undeserving sick who've bought it on themselves. I put the quotes around it with my eyebrows, and most of this spending will be devoted to people who fall into what the press would regard as the latter category, and I think we have to bear that in mind as well. I understand it's hard when you have a child with a genetically inherited condition who is in no way to blame for their condition, who needs a medicine, and we're putting the money into maybe drug prevention programs. These are difficult issues. I don't think anyone pretends they're not.
Nanette, please. Melanie.
I think we're all very committed to the basic principles of the NHS, that patients should have their health care as they need it, free at the point of delivery. But how sustainable do you think the current system actually is? And do you think it can be sustained into the future?
Personally, I'm optimistic on that point. I mean, my history of studying the health service goes back to about 1990 or something like that, and I would say out of those, nearly 25 years, for at least 20 of those, the NHS has been in some form of a crisis, and people have been talking about, the fact that it might not be sustainable, and it's underfunded, and gaps are building up, and stuff like this. You could find almost exactly the same speeches in the 1990s that we're hearing today about it won't last much longer unless something dramatic is done. That's not to say there isn't a problem, that's not to say there aren't pressures, but it's to say there always have been pressures. And the only gap I would see in there, in fairness, was in around 2002, 2007, when the Labour government put resources into the health service at a rate I don't think we've seen before, and possibly never will again, the way the economy in the UK is looking just at the moment. But it did give a level of resourcing to the health service that arguably it couldn't absorb very well, but it did give a level of resourcing that took those pressures away. So I think it is sustainable. I think we've got a very... It's a weird thing, in a way we've got lots of fixed costs within the system and lots of fixed elements, but it's also very flexible. People adjust, people adapt. We rely on the likes of Richard Lyle to only go to his GP once every 7 years to keep enough space for the rest of us at the GP system. The system is a very flexible and adaptable one. The principle at the end of the day is a system that is largely funded by the taxpayer to pay the bills and to have the services provided within the public sector. That's quite an adaptable idea, and it stood the test of time. So I'm optimistic.
I think it has been interesting how the last 5 or 6 years compares with that period 2002 to 2007, when money was being thrown at the health service, and instead now money has been it hasn't been withdrawn, but it's been much more difficult to see new resources come into the health service. So in a sense, that's evidence that it is quite adaptable, that has happened. Interestingly, the issue around costs. So why has the health service managed over the last 5 or 6 years? Partly because wages and salaries have been much more restrained than they were in the 2002-2007 period. I've seen an article recently that suggests that, in fact, overall, over this whole period of time, wage costs in the NHS haven't increased more rapidly than those in the economy as a whole. But what is important and affects cost is that the health services, unlike say your standard manufacturing enterprise, where as you use new machinery, you replace people. In the health service, as you introduce new and more sophisticated technology, you switch from relatively low qualified people into more higher qualified people, and that actually, just in itself, that changing mix drives up wage costs rather than wages per person being driven up. One area that I think is still, however, where I'm not necessarily optimistic, is around this social care aspects and the costs of those. We have free personal care in Scotland. That doesn't mean free care. And that is an important distinction to make. And there is a question, no country has all that effectively set up a long-term care insurance system. But we do have issues, and will have them increasingly as the population ages, of effectively people with dementia having a quite different outcome financially from those who have cancer. And so, that I think is still an issue that we need to think about. What does equity mean in those circumstances?
Sort of context. I mean, this is where adaptability has to come in, and we have to look at maybe different ways of providing services for the increasing number of people who are going to need increasingly complex services.
Well, so I think about to do some work on comparisons of England and Scotland in respect to social care. It's not obvious to me that it's necessarily the case that Scotland is more expensive because of the effectiveness of the free personal care policy in respect of keeping people at home. But we have to do the work on that.
But I suppose the contradiction there as well, things get more technical or highly skilled in the acute sector, and it costs more as we push out that other level of care, either in the acute sector to nurse assistants or in the community to carers, etc., etc. Then it's the opposite is in place in terms of driving down costs, and it becomes a driver, doesn't it? I suppose to push it out the acute sector into the because it is cheaper with all of that goes along with that. Sometimes impacting on quality, sometimes on the patient experience, but not always. But on the people that are delivering that care, accelerates our inequalities. It accelerates the problems associated with. Poor wages, etc.
Yeah, I mean, if you roughly, these figures are not necessarily absolutely accurate, but they're of the right order. A week in a acute ward, say the average between that and geriatric, maybe £4,000 per week. A week in a care home, £600, £700 a week. And then you're paying maybe somebody 40 hours at a cost of £7 to £10 an hour, looking after them in their own home. Clearly, those are not complete substitutes, but working at the margin, if it's possible, to move things to lower cost outcomes, it can make a huge difference.
But one of the big barriers is it's hard to take the £4,000 out of the hospital because the £4,000 is the fabric of the building and the staff who work there, and we're not planning to take any of those out. So part of the block that, coming back to Richard Simpson's first question about is that it's so hard to take money out of a hospital structure.
Does that in terms of focusing on the 2020, does that, and in some of the the criticism that you had about recording information, comparing outcomes and performance levels, etc., etc. Do we need to, does there need to be some sort of review of that whole system, so the information that we are collecting is useful in terms of describing the outcomes, whether things are getting better or worse or whatever, how we can improve them. And I suppose financial planning for all of that. And the third question is, should we just be doing that in the health service, or do we look at, health, social care, well-being? Is it a new model? We're just looking at health here, and we know from our previous work that while health is dealing with a lot of the outcomes, that dealing with this issue is much more complex, and it's about people's life chances. It bring them there earlier or later or whatever. So are we just looking at this, just in a box? Even within the box, do we need to look at that more in a more simplified way, that we almost get too many targets and whatever? Do we need to review the performance, understanding the performance and financial planning and these much better than we do now? Is that something useful the committee could do?
I think it is. If you were, as Andrew said, maybe the way of incremental budgeting that we've done since the inception of the Parliament is appropriate. But if we thought that wasn't appropriate, and you went to a zero-based budgeting approach, would we have information in place that would help us or inform us how would be the best way to go about that? And it's not clear to me that kind of information is available. And I think the committee could do an important job by trying to have a look at what kind of information those people who might plan the system somewhat differently would need to be able to take that kind of plan forward. In relation to the health and social care interface, actually I'm doing some work with the Scottish Government at the moment on the first kind of joint data set that has been made available, which integrates social care information with health information. There are people from all over the world who think this is really innovative, because basically other healthcare / social care systems haven't got as good data as Scotland has. But we're just at the moment kind of scratching the surface in relation to this, and I think it has huge potential. It has huge potential in positioning Scotland as one of the leaders in terms of the way we understand this integration between health and social care.
I wouldn't necessarily advocate a bonfire of the indicators, convener. I don't think that's what I'm suggesting. It could be tempting to say we've got 120 indicators in total. That's too many. We only want 20. But part of the fascination, I think, for all of us involved in scrutinising health is its multifactorial nature, going right the way through from very simple public health interventions through to very complex hospital-based things for very sick people. And you need a range of indicators to catch all of those. I think my frustration at the moment is they're all put under one heading. And if we started to think of them in groups like the public health group and the healthcare experience group and other groups like that, then that would be a way forward. So when we look at things year to year, so when I looked at the performance indicators for last year, it looks as though a lot of the public health things are stalled. If you look at the trend, it's actually in the right direction, but there's not much change year to year, and we should probably put those to one side and say, let's only look at those once every 5 years or something like that, and let's focus on a different set. So it's having different sets of indicators more clearly for different purposes, where the clue as to what they do is in the title, and they don't have very general titles like quality monitoring framework and heat and things like that, because that doesn't tell you what's in there. So I would keep probably the range of indicators, but have them more clearly grouped for purposes. And I would definitely think about the integration of data systems across the health and social care divide, because one thing we do know, and as we're demonstrating with the draft budget document, is attention tends to go where the numbers are. We're focusing on the 20% of the budget where there's the numbers, because we don't have the numbers for the other 80% of the budget. If we get that equivalent situation in health and social care, where all the information, let's say, is on the health side, despite Professor Bell's misgivings about ISD and their contribution, and there's very little on the social care side, we're going to end up with a skewed debate about what's going on. So I think it's really important that we get those integrated data systems from the start.
You did mention earlier, though, that what's going to be happening in a decade's time, it's important to understand that we're on a journey. Yeah. And Bob mentioned the problem of poor politicians who need to deliver on a 5-year scale. You know, a hospital manager or chief executive is judged annually in some of these things. And you know, and all of these indicators, you know, I mean, I just think that's, you know, not.
So I think that approach is open to challenge it, and you know, and my idea of grouping them would be more clearly about, you know, if something is going wrong in the system this year, that leads to a waiting time problem, for instance, and that is something which should be setting a red light flashing. The fact that physical activity in a population at a particular health board didn't go down from 2011 to 2012 is a long-run warning, and if it didn't happen again in 12-13 and didn't happen again in 13-14, you know, it didn't happen over 5 years, you'd be worried about it. But it's how quickly it triggers a response, I guess, and making everyone in the system aware of which ones are the ones where there will be questions asked within weeks if they're going wrong, and which one, frankly, we're talking about a 5-year timescale. I think that's the essential difference between these things.
Is there any other questions? Can I express the committee's appreciation for your attendance here and your submissions, and thanks very much indeed. Thank you. We suspend at this point until we set up. We've got a round table or something. With our agenda, which is number 3, the continuation of draft budget scrutiny. We now have a round table of stakeholders. We'll just get by this and just, I can, as usual, we'll just introduce ourselves in the round table if that is okay. My name's Duncan McNeill, convener of the Health and Sport Committee.
Bob Doris, Deputy Convener of the Health and Sport Committee.
I'm Jill Vickerman. I'm the Scottish Secretary of the British Medical Association.
Richard Simpson, MSP Mid Scotland and Fife.
Hello, I'm Annie Gunnar-Logan, Director of the Coalition of Care and Support Providers in Scotland. Convener, I should state for the record that I'm also a non-executive Director of the Scottish Government, but I'm not acting in that capacity today.
Richard Lyle, MSP Central Region.
Good morning, Lillian Macer, Unison Scotland, Convener.
Colin Keir, MSP for Edinburgh Western.
Kim Hartley, representing the Allied Health Professions Federation in Scotland.
Nanette Milne, MSP for North East Scotland.
And hello, I'm Rachel Cackett, and I'm a Policy Advisor for the Royal College of Nursing in Scotland.
Thank you all for that. Just kick off the general question, and hopefully, the members will understand that I always give our panel members precedent here, and before I'll give them the opportunity to ask questions. I suppose the general question will be, is the allocation of resources in line with the Scottish Government stated priorities as set out by the draft budget? Who's going to be first? Rachel, please.
Thank you, Convener, and I feel like I should somehow justify my invitation, which is very welcome to come and give evidence, by saying something new. And having sat through the previous session and having come and engaged in these conversations before, it's sort of hard to find the thing to say that's quite different from what's been said before. And in a simple answer to your question, I think the answer is I don't know. And I think that's probably what you got from your previous speakers. What I would welcome is, I think, where I heard the conversation going in the first session. And I do think we have a set of documents in front of us that probably set up a set of parallel conversations that should be joined up. And it's that joining up that I welcomed in the earlier conversation. We've obviously got a set of documents that give us allocations within an envelope of money that's available. And on that basis, we have to acknowledge that the NHS budget, the health budget, is in a fairly privileged position in the context of fairly straitened public sector spending. And I think it's also worth noting that there isn't much change between the 2015-16 proposed budget and what was proposed for 2015-16 in last year's budget. But I think it can easily push us towards that discussion around allocations at the margin and whether the budget lines are right. And the information that we have, I think, doesn't allow us to have a very easy conversation around the bigger issue, which is the second conversation in parallel, which should be joined up. And that is, how do we create a sustainable and quality future for health and social care in Scotland? And that is a conversation that can't be at the margins. And that's why I welcome the discussion that the committee was having earlier this morning. I think those aren't discussions around small changes in individual budget lines. I think they are discussions that we need to have with the public, with staff working across all organisations, with the various political parties, around how do we take into account not just where the allocations are, but how those are then reflected in how we meet demand, how we meet expectations of our services, how we meet the cost of very welcome developments in technology that Andrew Walker was talking about extensively this morning. And we've discussed how to have that robust and transparent debate before. I guess we are in a different position now that in the past few months we've seen Civic Scotland engage in discussions around the future of Scotland in a way we may never have seen before. So I suppose my question is, if we can't get that discussion on the table now, then when? And that seems to me the question in this that we really can't quite answer from the documents that we have.
Anyone else? Annie? Then Kim?
Thanks, Convener. I agree with Rachel that there's a sort of Groundhog Day element
to some of this, and I was looking back at the evidence sessions from the last 2 years, and again I was struggling to think of what I might say that's new or different, because I think a lot of these issues are still with us and are quite intractable, and that's come out in the previous discussion with your other witnesses. I mean, from my point of view, it's the social care element of this that is of most immediate concern, because my members are delivering social care rather than health care. And once again, I'm drawn to the budget document talking about health and social care in Chapter 3, and then only talking about the health budget in Chapter 3, whereas I think it's Chapter 15 is local government budget, and that's where social care has always come from and probably will continue to come from. And it's very much the last discussion you had. I think Professor Bell was absolutely right in saying that it's at the local level that this will or won't be resolved. And so the scrutiny of the health and social care integration authorities is going to be extremely important in relation to the targets that we have. And yet another thing that I said last year that I'll say again as well, which echoes your previous evidence session, is around the plethora of targets and outcomes that there are. I mean, your witnesses mentioned the National Performance Framework, outcomes and indicators, and the HEAT targets, but we also now have national outcomes for health and social care integration, which may or may not link to any of the other two. You've got single outcome agreements at community planning partnership level, and then you've got care standards which are under review as well. So it's not just the ones that were mentioned before. There are all of these targets and outcomes, and it's very difficult then to figure out which ones are the priority, which ones are national, which ones are local, and how you actually marry up these budgets together. And as well as that, of course, you've got a whole series of policy initiatives, such as reshaping care for older people, shifting the balance of care. So if your question is, is budget allocated appropriately to priorities, I think you first have to figure out, well, what are the priorities in effect? And they might be different at different levels and for different organisations. And I mean, in effect, that's the challenge of integration.
Okay, thanks, Annie. Kim?
Thank you for the opportunity to come back for a second year, just our second year, to talk about talk about where HPs see this budget. It is, even though it's just a second year for us, similarly a bit of a Groundhog Day, but really to pick up on the points that quite a few other people have said, we can't tell, the Federation can't tell how this budget is going to play out for service users. But the current trends are definitely not encouraging. The impact that this will have on either the targets or the aspirations or the experience of patients will all depend on the awareness and buy-in at a local level, really, of awareness and buy-in to the value of HPs in local authorities and in the NHS. From the HP perspective, the money definitely is not shifting at the moment, and as I said, we can even tell from the figures that we've got that things just don't look very good for us. If we can take some of the table that was held at the end of the SPICE briefing, Table 5, which tries to align the expenditure lines with the different commitments within the budget. The one bit of budget that we're mentioned in, which is about the NMAP budget, which has in fact been cut, that's meant to cover nursing, midwifery, workforce and workload, which is obviously fantastic, but they're just part of a much larger workforce. We know it's to cover all the health visitors, so increase in health visitors, so that's us not getting a look in there either. The other budgets that are important to us, things like e-health, tiny amounts of money going to the sorts of value that AHPs deliver. So we know just from those figures it's not good, but the trends sort of in the health boards from previous years, and Health Committee knows this, doesn't look good either from the funding from health boards or from local authorities. I think we are sadly not in this. A lot of the previous witnesses and a number of people talked about information. It's really important to state that the level of data that we have on the productivity, the experience, the performance, the difference that AHPs make, anything, waiting times, waiting lists, anything like that, the inputs, we don't have a clue about that at national level. So deciding what impact the budget's going to have, for the care groups that they work for, and that the major input that AHPs have. We don't have the intelligence, so we can't, neither at a central level or at a local government level, do we have any means of telling. They don't have the intelligence they need to use the money effectively for AHP services. So, yeah, really, I suppose we can't tell, but it doesn't look good, is the short answer.
Jill?
Okay, thank you very much. I appreciate that the BMA has had the invitation to speak here before, but this is my first opportunity to do that, so I can't repeat myself from the last time. But I will try to not repeat too much of what others have said, because I do agree with a lot of the comments that have been made, but instead to try and build on that. I think in terms of the answer to the specific question, like others who have commented, it's very difficult to tell whether or not the allocation is in line with Scottish Government's aspirations. I think the conversation that took place earlier this afternoon, this morning, about whether or not you can change the high-level budget lines to drive change in the way that health services delivers is slightly worrying. I think our perspective from the BMA is that we really are actually in different times now. There are significant and very worrying pressures across the health system. I don't have the same level of optimism that if we carry on doing what we've always done, we're going to be able to manage to do that within the approach to sort of budget allocation that we've currently got at the moment. I think, though, the point that Annie made is absolutely right. This requires a sort of stand back and an assessment of how services need to be delivered in the future before a decision is made about how then budget lines are applied to them. And at that point, we might be in a better position to see something about whether or not we're applying budget lines in a way that reflects the aspirations of Scottish Government. So the BMA, I think, like many other stakeholders and yourselves, entirely supports the high-level aspirations in terms of the 2020 vision, but we don't yet see the way that is being played out in terms of the approach to delivering services, the way that health boards are able to make decisions themselves locally. As again others have said, it's really important to sort of free up that ability to make the decisions locally about how to pursue that vision, and the sort of pressures that central government are putting on health boards through the existence of targets, etc., is diverting some of the ability to do that. So, as I say, in terms of the specific question, not possible to tell at the moment, but serious concerns that the range of pressures that exist and the lack of flexibility does not allow underneath the high level of budget lines for resources to be applied in such a way that they will achieve the aspirations.
Lillian.
Thanks very much, colleagues, and thank you for the opportunity to have the debate and the discussion around the budget and the proposals related to that. One of the things for Unison, in terms of Unison Scotland, we are probably from the staff side organisations in a very unique position where we organise not only in health but have significant membership in the local authorities, and for us that we see that as not a challenge but an opportunity around health and social care integration to bring both of those workforces together in relation to delivering better outcomes for the population of Scotland. So we see that primarily as an opportunity. Again, not disagreeing with what colleagues have said in the room, there are significant challenges for health boards in Scotland. For me, I suppose I need to declare an interest. I'm not only Unison Scotland convener, but I'm also a worker working in the health service, and indeed a board member as an employee director within NHS Lanarkshire. So I've got very practical knowledge of how budgets are allocated within the health systems, and very practical knowledge of how those are delivered for health workers, or for the population in Scotland. The desire to move the budgets from the acute provision of care. We heard earlier the discussion about the continued investment in acute, not only in beds but in facilities and indeed staff. I would suggest that one of those opportunities in terms of that is around the investment in staff, which is absolutely crucial to the agenda for delivering health, social care integration, but also health services in Scotland. The one thing that you can absolutely guarantee is an investment in staff is not a wasted investment, because those staff have transferable skills. They can move from an acute setting into a community setting. So therefore that is an excellent investment, I would suggest. And in Unison's submission, we've laid out some of the areas where we think we should be looking in a bit more detail. And I would very much welcome that debate and discussion this afternoon.
Well, we heard earlier this morning, that this situation and the crisis in the health service has been around since we've been around, and even when lots of money was going in, then there was a crisis, and it hasn't brought us down yet. So what's different? Yes, Jill.
There clearly have been peaks and troughs over the course of the last 20 years, and no doubt more than that, in terms of the sense of crisis and the levels of morale and the concerns that there are amongst all of the different staff groups involved in delivering and planning healthcare. But what we're seeing in doctors at the moment are some very specific and new problems which are hugely concerning. We have in 2 of the health board areas over 20% vacancies in consultants. We've never seen anything at that level before. We have a weekly crisis to deal with in terms of whether or not GP out of hours and accident and emergencies units are going to be properly staffed. We have some significant problems in terms of filling partner posts in general practice, and we've got some real issues about trainees choosing to train in Scotland and fill our training posts. So these are levels that we haven't seen before. I think Andrew and David talked at some length about the range of different factors which are contributing to the pressures on the health service. These have come together, I think, in a perfect storm in a way that we predicted, but we haven't had the economic pressures, the level of population change, the increased life expectancy, but with increased levels of multimorbidities, and the pressures of the expectations and the behaviours of public all coming together in the way that they are right now. So we are genuinely seeing on the ground through our members a very significant difference in terms of what has been experienced before. We've got levels of planned early retirement where we haven't seen them before as well, so we can see this continuing to get worse unless we have that very honest debate about how we change the way that services are delivered if we're going to continue to manage to deliver high quality services in Scotland.
Yeah, I think, thank you. Reiterating what Joe's just been saying, really briefly, the demography demands we do things differently, that we have to have a different model to not letting people get ill, and if they are ill, dealing with them in much more, or providing care in much more efficient, further away from that expensive acute care, and the whole agenda around shifting. I think the patient expectations, the needs of the population have changed, but the political expectations and needs have changed and become a lot smarter in terms of, as you said earlier yourself, there's a consensus in the way that we need to be delivering care, but although we've got that impetus, we've not got the actual change on the ground because we're not changing who and how we're making decisions. That's why the crisis is getting more and more acute.
Yes, Rachel.
Thank you. I do think we have to bear in mind that one of the reasons that we're facing this very particular crisis, and I'm not going to repeat what Jill has said, I think that is a fantastic summary of why we're here, is down to the success of what we have done over the past. We do now have much longer life expectancy, though that is not always good, healthy life expectancy. I think some of the figures that were in the report down south on the 5-year plan, when you're looking at cancer survival rates, are significantly better. But that does place an additional strain on the NHS in terms of healthy life expectancy and how long people are living and how people who are frail into very old age require very complex services. So I do think that is a real addition. But I do think we have a real opportunity here, because there are really creative things that I think we could be looking at to how we deal with some of these issues. So Jill was talking about some of the issues on recruitment. Now that's an issue for many parts of the service, but I know when the Auditor General reported on issues in Orkney, and we have issues in our remote and rural areas that are very particular sometimes to the recruitment of staff, how we're dealing with that specialist input that we were talking about in the first session, as things become more complex, so you need more specialist input. But also there are really creative ways about how do we think about what this workforce of the future will look like. Who has to be doing what? Do we always have to rely on the traditional models that we've had in the past? Or actually do we have skills that are spread both through the professional workforce, but also how we take into account people's ability to and desire to manage their own care, the role of carers. We need to be doing this in a very, very, very different way, rather than simply throwing money at what we have known. And that, I think, is the big discussion in terms of sustainability and quality that we need to be having, rather than simply looking at where the gaps are and saying how do we fill them in the ways that we always have.
Bob Doris.
I suppose just kind of briefly, because we're scrutinising a budget document, and I'm listening very carefully. Where the BMA has made powerful cases before in terms of recruitment, retention, and filling vacancies across a range of specialities, and they've spoken about distinction awards and the 9-1 rota system. So those are on the record before. I know I've met with Kim Hartley and other colleagues in relation to how allied health professionals can help support a 7-day service in stopping daily discharges and a variety of other things. And these are, if you like, workforce management and workforce planning and skills development and all those things. And I get all that. And I know there's a number of work streams ongoing, and this committee could look at those on there as a standalone. But what we have in front of us is a budget document. So I suppose it's how we tie in a high-end budget document to the, if you like, the concerns or the comments that you're making here this morning. Because we look at a budget document and we go, oh, it's a 1.1% real terms increase to territorial health board budgets. That becomes meaningless in itself. It all depends how that money then feeds in and what it's spent on. So can we read anything into it? As much as I totally respect and take on board all the pressures and tensions and stresses and strains in the system that you bring here today, how do we tie that into this, if you like, headline budget document? And the obvious question we always ask, convener, every single year, and this is deja vu for everyone who's been at this committee over the years, is you can't spend the same pound twice, which is obviously why the conversation earlier on headed on to, well, what might you not do? How might you reprofile some of that expenditure? And that's why we're talking about targets and outcomes, and then are there savings from that, and could you redirect that? So, as always we do at this time of the year, convener, you know, how can we look at this headline document to the specific concerns you have, or do we have to wait till later on where we look at NHS boards setting their budget, and what would you do differently? And apologies for everyone who's heard this question again and again and again. It should mean you've got pretty slick answers for it, I suppose, but we do have to ask these questions.
Yes, thanks, Bob. I think that is the right question to be asking. I mean, my answer to it is always, you know, look at what's in the budget that actually will leave a change. And we heard from the previous witnesses that, you know, there's the integrated care fund, there's the resource going into to support integration out of this budget. But if you look at Chapter 15, you know, again, we hear from our witnesses that it's the local government settlement that's going down. So social care will be under much more pressure than NHS services. And I don't think, you know, £100 million worth of an integrated care fund is actually going to make up for that. So I'm always very interested to look at what is it in the budget that is going to push forward that change, and that there's something in there, but it's not quite enough, in my view. it's the scrutiny of what the health and social care integration authorities do next, which is going to be answering your question, and what stimulus is given to them to do things differently. I mean, to go back to my point about targets, you know, if you're a health board and you are very seriously performance managed on things like treatment time, waiting time guarantees, then you are probably going to prioritise your resource to meet those targets. Yeah. You're then going to look at the national outcomes for integrated health and social care, and you're going to see a number of aspirational outcomes, such as, you know, people who are frail are able to live as far as reasonably practical independently and at home, and you're going to look at that next to your treatment time heat target objectives and say, well, which of those am I going to prioritise? So, you know, there's a bit of confusion in here about exactly what the objective is and how far that's shared across the different agencies that are now being expected to come together to deliver some of these things. And I'm not convinced that the levers that are in there in the budget are sufficient to drive that. What we'll see is joint strategic commissioning locally. I mean, we had a bit of a discussion there in the earlier session about incremental budgeting versus zero-based budgeting versus outcome budgeting. And it seems to me that what health and social care integration authorities locally are being expected to do is what the government is not doing in this budget. If this is an incremental budget, joint strategic commissioning is supposed to be about, not quite zero-based, but certainly outcome budgeting. So that's where the focus is, but this budget doesn't do it itself, if you see what I mean.
Jill?
Thank you. I think I'll go back a little bit to the answer that I gave at the very beginning to the first question, which is that there needs to be a piece of work done which we do not underestimate the size of this, and it really goes back to what Rachel was saying earlier about revisiting how we deliver healthcare services. It is not possible, as the leaked paper from that was discussed with chief executives and Scottish Government, to continue to do what we're doing every year here and have a marginal increase in the health budget and be able to sustain the delivery of healthcare services. So for me, it's more a case of, if we carry on doing what we've been doing year on year here and have this level of increase in the health budget, we aren't, excuse me, we're not going to be able to deliver healthcare services by 2020. So but what's missing for me in this is the message about what's going to change if we're going to make the healthcare system sustainable. And I think that's the point that Annie's making as well. There isn't evidence about what the levers for change are here. There's very much a continuation of the same as last year and the same as the year before. What we want to see in even the high-level budget is a signal that there's a recognition that there needs to be a shift in the way that the budgets are spent, and that will largely be when you get to the stage of looking below the health board lines, but there's nothing even at this level which gives that sense of a commitment to make that change.
I just want to pick up on something that Annie was saying and really support that. We, as you know, as the committee, have been looking at health board spending for some time now at the Royal College of Nursing, and we're having to really rethink what that might look like once health and social care integration kicks off from April, because the level of detail that we get at the moment won't necessarily transfer into that new world. So I would agree with Annie that the levers that should be in there should come through joint strategic commissioning. And there is something about how the expectations on joint strategic commissioning to do some of the things that we haven't yet managed to do nationally around choices on investment and disinvestment are a tall order for brand new organisations that are going to come together and have never done this before. So my concern, I think, is that we are going to place that expectation on our new integration authorities to make really difficult decisions, to consult on those appropriately with people using services, carers, staff, the general public, and they are going to be very, very new. Now, one thing is that we don't know how that scrutiny yet is going to play out. There's obviously a lot of work going on with the scrutiny bodies, but certainly in terms of what future budgets look like and how we sit around this table in 12 months' time and look at how decisions made at a local level impact on your questions around outcome and impact, I don't know yet. And I think that's going to be one that we're going to have to really grapple with, because those big decisions will not be taken at this level within the budget. They're going to be taken at a very different place. But certainly as a college, we've started looking already at the first iterations of commissioning plans that were put together around older people, to look at what's the impact on our constituent bodies, on nursing. What are the things that we're looking at that will make a difference? What is this telling us about what the nursing workforce will need to look like in the future? And my hope is that those strategic commissioning plans will help all of us to start doing that. They should. I mean, ISD is doing a lot of work at the moment to support the needs assessments that will go into those plans, that will hopefully ensure that services are designed in a way to meet outcomes and improve outcomes. But I would also just make the note of, again, going back to the auditor's reports on Highland, and I know that was specifically around acute spend, that was around Raidmore, but there was a comment in there around the speed at which the shift of the balance through integration, obviously Highland being ahead of everyone else by a couple of years, how long that is likely to take. And I do think we have a situation where the first joint strategic commissioning plans, I would guess, are unlikely to be radically different from what we already see, because these are new organisations finding their feet. It may take us 3 or 6 years to get to the point where there is the evidence and the consultation and the decisions made to do something radically different. The difficulty is we have an issue now with pressures, whether that's through social care and Annie's points around the local government budget, or whether that is the discrepancy between the welcomed increase in the health budget, but the impact of other cost pressures within the health service as well. So we do have that timing issue at play here, and I think we have to be careful on what our expectations are of integration authorities come April 2015. They have a massive job ahead of them.
Thanks. Lillian?
Thanks, colleagues. One of the things that perhaps I could pick up, and I absolutely hear your question, and if it was a straightforward answer, you would have had it all those years ago when you started to ask the same questions. There is, however, I think it would be worthwhile having a discussion around some of those pressures that colleagues have described in relation to our population living longer. That's an opportunity for us to celebrate some of the successes, but within that we need to understand and recognise that that population isn't necessarily a healthier population. So therefore that becomes another issue for us to deal with in health boards and indeed in local authorities, where we need to put provisions in place to support that elderly population, but not necessarily that healthier population that we're creating in Scotland. And again, one of the opportunities that we see, certainly within Unison around the strategic commissioning, is also around some of the procurement elements of that, where we have the opportunity as the public sector organisations with the biggest spend in Scotland to procure goods and services that will enhance and support Health Board and local authorities' aims and objectives to make a more healthier population. This is a real opportunity for us to make sure that the spend that health boards have, the spend that local authorities have in relation to the day-to-day running of those services is spent in the local populations. And we've said in our submission that we need to look at some of the community benefits realisation that this opportunity will afford us. And I think that for us in Unison is a real opportunity, and we should take that forward. Within some of the pressures that have been identified, and I know, Bob, in your question that you said we hear the pressures in workforce, but I think it's absolutely crucial that we have that discussion around some of those pressures in the workforce. And Jill rightly said about the vacancies and consultant vacancies within health boards in Scotland. And it is absolutely right that we have the senior decision makers in the boards making those decisions, but it's also absolutely right that we have staff in those boards who can support all of that work. Well, that might be in minor injury units, it might be in major units within accident emergencies in Scotland, where we have some fantastic initiatives around mince minors and mince majors, where the workforce, nursing workforce, AHP workforce are delivering on those areas. So again, I think we need to look at that. We need to look at some of the staff, the support staff within those areas as well. We are a healthcare team. We need to be a health and social care integrated team. And again, I think Unison is best placed to support that with that cross-sector membership. One of the areas that we looked at in Scotland, and we've looked at for the last 2 years around the 2020 workforce vision, is indeed Pan-Scotland workforce planning. We've got some fantastic information and evidence around the Pan-Scotland workforce planning. We've got some information and evidence that we need to produce. However, health boards currently don't have the capacity to do that. They don't have the capacity to undertake the scenario planning that was identified as an absolute must, to look at those areas where perhaps we have cliff edge of staff who are about to retire as we move to new pension provision in 2015. People are concerned about the increase in contributions in their pensions, something that's not been mentioned already in terms of the workforce. And they're also looking at how best they can use their own pension provision going forward after 2015. We have an ageing population, which means we have an ageing workforce. And that workforce will be looking, as Jill rightly said, at some retirement provision for themselves as individuals. So I think there's a huge amount of work that we need to do in terms of workforce planning. I think there's a lot of work that we have done, but I think we need to join all of that up. We need to join up the work that's been done for the workforce within the local authorities and within health, and look at an integrated workforce, and we're not there yet. We are not very good in health boards at workforce planning, but we do have some tools and within our systems that will allow us and afford us that opportunity to do that. And that Pan-Scotland work that was done over a 2-year period, I think we should be looking at the 2020 workforce vision that we've got, and we have staff representatives in health boards dealing with that, and indeed at a Scottish level, and also some of the work that we're doing with an engaged workforce around iMatter. There's some fantastic initiatives out there. We need to allow those the opportunity to develop, but we also need to look at beyond the health service workforce and into the integrated workforce. One of the areas I think where we've sadly not had the opportunity to put into legislation is around the staff governance agenda. Significant issue for Unison in terms of that workforce, but it also would give us the opportunity, if we had a staff governance framework across the public sector and indeed in the private sector, the opportunity to bring in the community workforce. We've got the opportunity to bring in the public and the private sector, and if we did have that staff governance framework, that would give people the support and the assurance around making that integrated workforce a reality.
You want to respond to some of that?
Yes, thank you. Just kind of sitting here pondering, I thought I'd have a go at answering Bob's question in a different way, which is not what isn't in the budget, but what would have been nice to see in it. You know, which would have maybe backed up some of these policy initiatives and outcomes that we've all been talking about since the year dot. And one of them would be a budget that said we are now going to make a massive investment in social care. And we are now going to make a massive investment in the kind of community support, a lot of which is in the voluntary sector, which is going to keep people well and out of hospital. And if you had that coming in, then you might be able to look at some of the savings that your previous witnesses were talking about in relation to the health service. Because there are any number of voluntary organisations out there that can say, well, what we do will save somebody being in a hospital bed for £4,000 a week. Actually, they're not going to. That's a notional saving, because they're not going to save that money while the lights still have to be kept on and the staff still have to be employed. And so the savings will come from actually stopping doing things completely, rather than sort of making differences at the margins. So huge investment in social care will be what will change that, I think, and a huge investment in community capacity through the voluntary sector. And instead of that, we have a local government budget which is shrinking. You have a social care sector which in many respects is being pauperised. You have a lot of social care, home care for older people being delivered by workers who are on minimum wage, with absolutely minimalist pensions. You've heard me say this many times. This budget isn't doing anything about that. We are expecting to see that happen at Joint Strategic Commissioning level, but as Rachel has said, we're early days there. And some of these same kinds of discussions are going to play out at local level because the drivers just aren't there. So that's one way of answering your question, Bob. That's what I would have liked to have seen in it, but it's not there.
Jill, followed by Kim.
Like Annie, I was having a think about how to more directly answer your question, Bob, and unlike her, though, I was going to have a look at things that were in the budget and have a look at the sort of level 3, and I guess that takes us to the conclusion that we've reached, that this budget document does not have a joined up narrative and plan as to how the various different lines of investment that are described here are going to come together to deliver the aspirations of Scottish Government. So I guess this dips into the conversation that was taking place earlier with the evidence that you were getting from Andrew and David, but we don't have clear evidence base for why we should be investing 55 million in health and health improvement and 41 in alcohol misuse. These are very important issues, clearly, but we don't at the moment have a clarity about how we make the decisions about how much we invest in and how we prioritise these, and how we prioritise them not just within the health and better public health category, but also how do we consider them alongside the discussions that we've been having here already this afternoon about the cost that we incur by not being able to fill posts, right from consultant posts right through to the whole range of health service providers. We've got vacancies there where we're having to fill with very expensive locums, spending massive amounts of money that could be saved with a different approach to workforce planning and looking at the way that we make the range of posts that we have more attractive to the workforce to come into Scotland. Which of the decisions that we should be making about how to achieve our aspirations of Scotland are most sensible then, in terms of driving how we prioritise expenditure in areas where we still don't have a very clear evidence base of what works and what's going to make a change when we've got gaps elsewhere. So that's a question that I would raise, and a request for a more joined up approach to thinking about how we plan across all these different budget lines in a way that maximises the impact of the investment that we make in each on the ultimate ambitions that we have set out by government.
Kevin.
Thank you. In answer to your question, Bob, but paraphrased, do we have to look at the budgets later on? Very short answer, I'd say absolutely yes. But I think particularly the reasons I would say that is because if we just look at the budget as set out, if we look at the briefing that was provided, what this budget is doing, and as we've said in the briefing that we submitted, this simply just reiterates more and more of the same way of doing things. It's not shifting anything. And I agree wholeheartedly with many of the speakers, but particularly picking up on what Rachel was saying, this is a massively tall order for the Integrated Health and Social Care Board, the joint boards or the joint committees, particularly in light of the fact they have very poor data on which to base their decisions on how they're going to spend their money. Where's the difference made? And several speakers have said that. What makes the difference, where and when? They have got no direct input in terms of expertise or information, certainly from an HP perspective at the moment. And they have, as has been demonstrated both at a national level and at a local level, there's a very poor habit of integrated workforce planning. We don't have that habit either nationally, and we certainly aren't going to have it at a local level, even though it's obviously something that's a good idea. It's silly if you're in a care pathway. It's silly increasing the number of staff that are delivering part of that care pathway if you're not going to look at, well, simply all you're doing is you're creating a backlog in some other part of the pathway. So yeah, I think it's really, really important that we look at what is happening at a local, how money is being spent at a local level, but that it would be helpful at this stage to highlight in the report on the budget for the committee that the trend, as we see in the national budget, isn't promising, or in the sort of national patterns of behaviour around, for example, workforce and the information and the intelligence we've got to make good plans.
See how hard we're all trying to answer your question as directly as we can, and I'm listening to what's being said around the table and thinking about previous sessions with the committee, and also thinking about reports from Audit Scotland recently. And I think probably the thing that's missing for me in this is around how do we get that understanding? We keep sitting around the table saying we don't know which things actually make the biggest difference. So where is the additional funding to actually support more of that understanding, so that in a few years' time, either around this table or around the table of an integration authority, we are clearer about what is actually starting to make a difference. Now, how those indicators and targets are set, and I agree with Annie that there are far too many and we still don't understand how they're all meant to link in. there is clearly work going on around the health and well-being outcomes that are currently in draft regulation and the indicators that go behind those. But how will we understand? Earlier, Dr. Simpson was talking about the family nurse partnership, and I would say that is one area where there is a lot of resource going into looking at what is the impact of that, and has been for some time in its incarnation in the States. There are other pieces of work as well, things like deep end practice. You know, these things may not be cheap, but at least we're trying to understand what the impact of that significant level of investment is. And that seems an important piece of work. The Royal College of Nursing has been doing a piece of work with the Office of Public Management over some couple of years now to try and work with nurses to help them quantify the impact of particular nurse-led services. And I know we've previously given some information to committee around some of the activity in Scotland on that, and that has been rolling out in Northern Ireland and Wales as well. One of the things I would note from doing that work is although the health service, and I suspect it's the case for social care as well, can be awash with data, it's not always collected, or the right data is not always collected to allow that level of impact to then be assessed, to know whether we're putting money into the right things. And we had brilliant examples of projects which we thought, you know, sounded fantastic pieces of work, but one of our difficulties in doing a robust piece of work with the Office of Public Management on economic assessment was they simply didn't have the right data to allow them to go forward into the programme and do that full economic assessment. So I think that's one thing we could invest in that would make a big difference to how decisions are made in the future.
I have to say, I asked the question because it was remiss of me not to ask it. I mean, I didn't expect anyone to say this is the silver bullet, do this and it'll work. Of course, I don't. I was trying to tease out, of course, we are scrutinising some headline budget figures, and I think that ever since we've been doing this, there's always a feeling of a disconnect between what the headline policies are and what practice is at a local level. And we're hoping health and social care integration may help tease some of that out, I suppose, and also accept that, you know, we don't expect an all singing, all dancing health and social care integration in April 2015. It has to bed in, and I get all that. I suppose the other tension I would just ask about is looking at our SPICE briefing. Of course, budget lines go up and down across the health portfolio. So, according to our SPICE briefing, specifically on the Family Nurse Partnership, yes, it's a very cash intensive programme, but we're all supportive across party on it. According to the SPICE briefing, it shows a 69.8% cash increase for Family Nurse Partnership, so a huge, significant cash increase. The reason I'm mentioning that is we can tie that directly in to this headline national budget that's been set, whereas, of course, the vast majority of monies that will be spent as part of the £9.6 billion going to territorial health boards, where you don't have that breakdown. So, I suppose my question is, would you rather have, it's a localism question, I suppose, isn't it? Would you rather have that £9.6 billion being a smaller figure and having other figures within the rest of the budget where nationally there's national policies and budget lines and health and social care partnerships or health boards or whoever just have to do it? Because from what I can see at the moment, it affects our scrutiny at this stage, but it gives more freedoms and flexibilities to territorial health boards and hopefully local authorities when health and social care integration comes in, and that might be a good thing. But the consequence of, I suppose, of Annie saying, I don't see the big thing in here, would be you'd have to filter away some of that revenue allocation to health boards and put it elsewhere within this health budget. I hope there's a clarity in what I'm trying to put here. People don't have to feel obliged to answer that, but that's the only way I can see that you could redirect spend from within this budget to do some of the things that I've heard around the table, I suppose.
Annie?
I think that's going to be your biggest challenge with health and social care integration, in effect, because you're dealing with a centrally managed NHS, having to negotiate on targets and outcomes and delivery with a very much non-centrally managed system of local government. I hate to say I told you so, but we did kind of point out that this was one of the kind of fundamental tensions with this agenda. Just coming back to something that Rachel said about knowing what works. I mean, in some respects, we do know what works around this. You know, we know that if there is good care at home available, then people will not be delayed in hospital beds, that they will be discharged. You know, we know that if there is good low-level support available for people, then they're unlikely to end up as emergency admissions in the hospital. You know, we know all of that, but we still find it very, very difficult to make that shift because there is a complete discrepancy between a protected NHS budget and an unprotected local government budget. Convener, I seem to be saying the same thing every time you come to me, but you know, I do think that is what is at the heart of this.
I will try and not say the same thing as I've said before, but there is a danger of that a bit as well. But I mean, in answer to the question, Bob, I don't think there should be a shift in the direction of travel. I think what we were saying earlier was we need clear evidence about why the investment in the things that are outside the allocation to health boards are going to have the significant impact on driving us in the direction of travel of the Scottish Government aspirations. So I think all of us have been commenting on the fact that we need the local bodies to have the ability to make the decisions about how best to spend the money and to have the freedom to do what is right within their local population. And this is where I will go back a little bit to what I said before. What we're not seeing, though, is the clarity about how the expectation and the freedom and the authority to make these decisions is going to be applied to the integrated joint boards and the health boards. And what we do see is evidence. This is where I'm going to go into the conversation about targets. We've got evidence that there are things that happen at a national and Scottish government and political level which stop some of the flexibility about local decision making taking place and create pressures which cost money and redirect resources away from where they have the maximum impact. So I think we've all been talking about the need to look at the effectiveness and the appropriateness of the targets that we have in place, particularly from our experience within the health service, where we have real examples of the current set of heat targets directing resources away from people who actually would do better for having them prioritised.
Rachel.
I mean, I think the Public Bodies Act is has been passed with cross-party support to devolve a lot of that decision-making about priorities and about how money will be spent to that very local level, and that's what we're going to see and learn how to live with. I'm with Annie that there are going to be tensions over the beginnings of that process, I think, with a tradition of a very centrally managed organisation knowing how to work in that very new sphere when some but not all of its services will be within the locus of the new integration authority. So I'm sort of with the previous speakers in saying I'm not sure the issue is necessarily about how much is ring-fenced centrally and how much goes out to health boards, and then beyond that how much allocation from health boards to integration authorities. But I will remember something that was said at the NHS conference a couple of years ago by the clinical director of the NHS about the fact that the NHS is not always good at upscaling. We have a lot of initiatives, we have a lot of projects, we have a lot of new ways of doing things that can be very, very good at a local level and then don't necessarily get the traction they need or the leverage they need to be expanded out in a way that makes sense in other parts of the country. And maybe that's where some of that central funding over things like family nurse partnership is actually very, very helpful to give that government support to trialling a new way of working, to evaluating a new way of working and making that available to partnerships.
Kim.
Yeah, again, or rather saying about the allocation of funding to our concern isn't about whether money's held centrally or that distinction you're making, Bob, about should we retain more money centrally and less going to the boards and to the local authorities. I think what could helpfully happen is that our concern is that wherever that money is, it doesn't seem to be working in terms of an integrated, fully multidisciplinary planning, whether it's central or whether it's local. I think what we could do centrally is start demonstrating the sort of integrated behaviour that we'd like to see, and we're not seeing that at the moment, and essentially to enable those local agencies to actually make some smart decisions based on the evidence and on the evidence base on real data, and that's not available at the moment either, certainly in respect of the HP impact.
Okay, you got any? I'm tempted to come back. I mean, but I think we are getting, you know, over the period of time, we've tried to focus on the last couple of years what's changing. We all agreed that there needs to be a shift from the acute sector into the community, and there's been bits and pieces, legislation, all of that. So, but in a draft budget, we don't see the shift in the money going in there. Indeed, we see contradictions and demands on the health boards and the health service, 24/7 working the trauma stuff. We see, we played a part in that as well. Increased spending on prescriptions where we expected savings that would have maybe channeled some of this in. We had, the treatment targets, which are distorting the whole service and prevents. So we've got a massive contradiction in there. We've got a draft budget that doesn't show any significant shift in terms of the change budget. When the change budget was there for older people, we had questions about how that was being spent. Was it just providing residential places or whatever? So even when we had it in place, and we don't see big significant shifts from the health service in terms of money into there, and we get a contradiction in politicians and government placing more pressure on the health service and increasing demand. So I mean, when is this shift going to take place? We're supposedly all agreed on it. We're all agreed on the 2020 vision as a priority. We agreed on all of that. We're taking the opportunity today with a draft budget to see whether anybody's serious about that or not. And there's nobody, and depending where you come from here, maybe apart from Unison, because they're straddling both, you'll say, well, it'd be a good idea to get more money locally because, community services might benefit from that. No, we can't give it away from the acute sector because we're dealing with this demand. So wherever you come from, it's about whether your chances are, there's nothing filling this hole in the middle. I know it's a bit rambling, but I'm just getting frustrated with it as well. There is no, and everybody's saying we need to do this, we need to do it quicker, and we're doing it, and it's not happening, and the draft budget doesn't give it the boost of the acceleration that it needs to ensure that it will happen. Jill?
I don't think the draft budget is a place to give it the boost and acceleration to happen. It's going to follow what happens. What we don't have is the plan about how we're going to change the profile of demand. And that's what I think a number of us around the table are saying. We really must have that open and honest discussion with the public, with politicians and with professionals and service providers about how we are going to shift the way that the demand currently falls. At the moment, all the budget can do is respond to where the demand is coming from, and as you rightly said, that is from the public's expectation of how they use health services and from the demands that are being placed on health service by politicians and the promises that are being made there as well. So we need to shift from that culture, which is where we've remained despite our rhetoric of needing to shift the balance, to actually a serious conversation about how do we change the way that people expect to use their health and social care services, how they take their own personal responsibility for the way that they use it and the way that they manage and self-care. And we need to listen to the range of stakeholders around this table and much more widely about how that shift needs to happen, and to stop making promises for new things in healthcare until we've got a clarity about what the plan is to shift the balance. And then we would expect to start seeing in the budget the evidence that is beginning to take effect. Without a plan, without something that we're all sticking to and agreed to and moving towards, we're not going to see anything apart from a repetition year on year of the same kinds of levels of budget demands where they've always sat.
I I'm sharing this, it's been trying to be a group therapy. We're sharing this frustration, if it's not really stress, but rather than the committee. But we're great and enjoy doing new things, but we don't like giving up the old things. So we spend all of our money doing what we've always done, and we heard from evidence this morning, a view it's not just expressed by the two economists, but we're changing things very much at the margins. And this draft budget doesn't come alone, it comes with conditions. The government's retaining a bit of money in terms of some of its initiatives. It's placing on health boards 24/7 working trauma stuff. It's placing on health boards significant targets, which is it's distorting the service, some would say now, and prevents money maybe shifting out. And it prevents all of these actions, and what we've been doing, prevent you thinking on the evaluation. And we contributed to that in terms of our recent work on access to new medicines, in particular to rare and end-of-life medicines, where we've got in the budget, because of the political, £40 million or so, which might cost more than that, and it could turn into treble, that amount going forward. But there's been no evaluation, as David Bell said this morning, between the benefits of investing in mental health and childcare, or family nurse practices, and any other, against that. There's no quality that applies to anything that we're doing that applies to new medicines, where people have been asked to justify the spend, the outcome as against the investment put in. And most of what we do, none of that takes place. So how can you have this debate with the public about what's important when we're all defending, basically the status quo? Rachel?
But I'm not sure we are all defending the status quo.
There'll be good, nice wee examples, mind you. They're all over the place, but it doesn't shift away
I suppose what I would urge is, I think, from conversations having outside of the room, that there are a lot of us who are willing to have the difficult conversations, because if we don't, if you look at a recent survey of RCN survey of nurses, something like 2/3 of nurses felt they didn't have enough time to deliver the care that they felt that they should be. We cannot keep doing what we're doing. The status quo isn't going to be possible. So I think there is something important about acknowledging that there are really difficult decisions to be made. Some of those will be decisions about disinvestment. People working in service are not going to be averse to having those discussions as long as they're done openly, transparently, and that there is a really good rationale for doing them, that they're done well. And I think that's where we're still placing a lot of faith in integration authorities to come up with those decisions about investment and disinvestment in particular that have simply not been taken more recently. And we have to have the conversation about, what is our hospital sector going to look like? What's it going to look like in the future? Because I think there are lots of conversations that I sit in conferences and hear about the freeing up of money from the acute sector to shift the balance of care to community. Well, I think we have two issues. One is when we were awash with money, we didn't do it in a way that allowed a level of double funding, and now we're in a situation where double funding 100 million to boards that's actually in their uplift, that is not going to be the sufficient lever. So how do we do that without impacting negatively on the care of people who do need the acute sector at the moment, because we haven't dealt with the long-term implications of reducing obesity or alcohol misuse or drug misuse or any of those things that will impact. So I think that's one of our issues. The other is, if our hospital system starts to look different, so the people going into hospital are actually the frailest, the most complexly acutely ill, then the cost of that acute sector are also going to change. So how do we do it? And that's where I think by engaging the public, by engaging staff, by engaging people who are using services in a debate about what is this going to look like is probably the only way that we will be able to start making some of the radical decisions that will free up the integration authorities to genuinely redesign services without there being an immediate outcry because people have not been brought along with what that actually means. And that's the situation we've seen repeatedly in the past. And we cannot do that in the future, because otherwise the quality of our health and social care services will decline in a way that none of us want to see for any of us.
Thank you. Well, yeah, AHPs, our service users, have absolutely no investment in the status quo at all. It's not working for our service users. We need a change in culture and hierarchy. I think it was Joe made the point that we don't have a plan for change or to change the pattern of demand. Well, we do. We have lots of different plans, but if I can talk about the HPs, we have a national delivery plan, specifically zero funding for that. Nothing's changed. HPs are demonstrating all the time how they prevent spending, how they increase self-management. The Early Years Collaborative is a huge example of tests of change, the difference, the savings that people are making. Contrast the amount of money that's going into, well, the Early Years Change Fund is stopping, more or less. Contrast that with the investment that we're making in one part of the early years funding. I think what we need to do in terms of shifting is to start demonstrating and celebrating an awful lot more loudly the evidence that we have in terms of what's making a difference, and do that with having different people talking about success rather than focusing on the same model of provision, which is about waiting for people to get ill and then dealing with it.
And then Annie.
Thanks, colleagues. A couple of things, if I could. One of the issues and one of the questions that were asked around, what can we do within the budget that would make a difference, in terms of shifting the balance of care, that would make a difference to health inequalities in Scotland. And very recently I attended a conference organised by the STUC in terms of looking at a Just Scotland, and one of the speakers, a couple of the speakers that spoke earlier in terms of presenting evidence were at the conference and gave some really, really useful and helpful information around, not just around health inequalities, but around income inequalities. And for us, one of the biggest issues and one of the biggest constraints placed around the public sector is indeed public sector pay restraint. Now, I say that, and I make no apologies for saying that, because one of the biggest issues for us is in terms of the workforce that we represent across the whole of Scotland, public sector workforce who deliver quality services, is around the ability to generate and influence the local economy. When we talk about localisation, we talk about how we can build from the bottom up, build locally to support public and private sector organisations within that local economy. And one of the biggest and perhaps the easiest way to do that is to generate and encourage spend. Now, public sector workers in Scotland, particularly the public sector workers I represent in Scotland, don't have huge bank books. They don't go to the stock market. They spend in their local economy. But the ability to spend in your local economy when you're under pay restraint, for the last 2 years having no pay rise, and the last year having 1% pay rise, when you've had 3.4% contributions increase in your pensions, that ability has been significantly reduced. So one of the areas for me, I think we need to talk seriously about public sector pay restraint in order to regenerate and refocus in the local economy. Again, the issue for us around the link between the health service and the link between the local authority, there is a huge demarcation between one and the other, and we need to get some serious and focused discussion around how we can stop that workforce at one point stop and then engage another workforce, and that's around the care pathways and how those care pathways need to interlink and engage with each other. Unison recently undertook a survey of its members and recently undertook a survey of service users around the 15-minute care visits, which we highlighted as being inappropriate. Again, it's a local authority issue, but it shouldn't be a local authority issue. It should be our issue. It should be the issue for the health service and the local authority. The integration agenda is our issue, and that's part of it. One of the other areas that we're looking at is the Ethical Care Charter, where people employed delivering that care are given training, they're given the ability and afforded that right to have the time to care and that time for training as well, make sure we have a trained workforce. And if we look at health services in isolation, We heard earlier about the Keepwell project, where boards have been asked to implement the Keepwell project with no additional funding, where some are saying that it's perhaps not given the benefits realisation it was badged to do in terms of health inequalities. I think for me what we need to do is look at where it has worked and allow the local systems, the local health economies to look at where Keepwell within a particular area has made an impact and has made a difference. We cannot continually look at across Scotland and say, well, one size fits all. Locally, in Scotland, Keepwell has made a significant difference for some areas of deprivation. Should we stop that? I don't think we should stop that. Should we support that through investment? Absolutely. But if we say to the policymakers in Scottish Government and policymakers across Scotland that it's not working across Scotland, therefore it needs to be stopped, that has a significant impact on local democracy and how the integration boards will generate localism and deliver health services and care services within Scotland. So yeah, I do think there's things we can do. I think there's things we can learn, but I also think that there's things we need to join up and we need to link, and we need to link policymakers with service. Working in the service, I hear all too often that there's an initiative coming out, the policymakers have decided on X, and then it's up to us to implement it and deliver on it without any additional resources, without any thinking about what it means for the local communities, and I think that needs to stop. I'm not saying it happens all the time, but when it happens once too often. So I think there's things we can do, and I think there's things we should do. But to say that we need to take a mature discussion around disinvestment, that's absolutely right. Because the first thing locally, when you say you're going to disinvest, if you say beds are old currency, we want to disinvest from an acute provision, the politicians will tell you that their local communities and their constituents don't want that to happen, so it doesn't happen. So I think we all need to have a serious conversation with the service, with the policymakers and the politicians.
Absolutely. We know the cost of arguing for change in the health service in my party. I'll say no more about that. Annie.
Thank you, Convener. I'm going to say some things that Lillian's not going to like. So I will declare an interest as a Unison member right here and now.
I'm giving a try my best,
but I mean, let me just preface it by saying that actually there is an extraordinary amount of good stuff happening out there. It's maybe not at scale, and it's maybe not measurable nationally. But self-directed support is something that I'm a great champion of, and it's doing that right now. It's transforming people's lives. It's getting a bit kind of hidebound with the bureaucracy, but let's kind of not forget self-directed support in all of this. But I wanted to kind of come back to what Rachel was saying about disinvestment. And if you're actually going to do new and different things, you need to stop doing some of the old things. And this is where Lillian's going to get upset, because there are things in this budget about pay commitments to the public sector and no compulsory redundancies which do not apply to the rest of the market for social care. And worse than that, they have been driven down, paying conditions in the voluntary sector and in the private sector have been driven down by public sector commissioners. So the extent to which you can disinvest, or it's made much more difficult to disinvest in public sector services because of these things that are also in the budget. And I think that's something that we actually need to face up to. It is much easier for a public sector commissioner to export pain to the private and voluntary sectors because they don't actually then have to manage it. And there are no commitments in our sector from commissioners or anybody else to no redundancies and maintenance of paying conditions and all the rest of it. So, even if you look at care at home, if you look at the quality of care at home provision for adults and older people in Scotland, the voluntary sector is absolutely streets ahead of either the private or the public sector. The private sector is cheaper, so you might think it would be worse, but the public sector is enormously more expensive, and yet it still does not reach the quality attainment of the voluntary sector. So even on a best value basis, why are we not investing more in the voluntary sector? Why are we not disinvesting, if you like, in public sector care at home if it's expensive and it's not as good quality? That's why I'm thinking that Lillian's not going to like this. But, you know, if you're going to have hard conversations about what to invest in and what not to invest in, you have to go to some of these places as well.
I see Lillian's coming in, and Rachel would like to come in as well. And then we really need to get to a stage where we're summing it up one after one.
I don't necessarily agree with all of which Annie has given to the committee. What I think we can do is agree jointly that there needs to be a level of investment that means that whoever delivers services in Scotland for the population of Scotland get the living wage. So that's a real significant issue for us. We think, and we organise within the voluntary sector, we have fantastic achievements within that sector where our members deliver where they can and where they are able to high quality services. The significant issue for us is around, you're right, that when public sector organisations commission or procure services, they pass over the pain. That needs to stop, absolutely. And that needs to be absolutely clear from, certainly from Unison, we've said that needs to stop. You cannot pass over the pain, as you cannot pass over the commitment to deliver the services, or you cannot pass the ability to deliver the services and think that you've washed your hands of it. All you do is you lose control, and when you start to lose control, you lose quality, and in that quality, the recipients of that care suffer the consequences of that. And when it all comes back to it, the people who have to pick up the pieces of that are indeed the public sector organisations where care providers, it is no longer deemed appropriate or a viable option to deliver that care, can walk away. But the public sector needs to pick up those pieces. So I do think there needs to be a playing field, a level playing field around the living wage, and that we should all be committed to, irrespective of it's public, private or the third sector, that the living wage should be the benchmark for pay in Scotland. And I think if you take some time, and you have some time to look at the Working Together review that was commissioned by the Scottish Government and the STUC, where significant players in that, you'll see there's some fantastic recommendations from that look at the workforce across the whole of Scotland, not just in the private sector or indeed with health or social care, but across all of Scotland, and those recommendations look at a workforce, a democratised workforce that gives worker voice, and part of that is around making sure people get pay, and the living wage would offer that security, I think. And so we don't necessarily disagree, Annie, on all of your contribution.
Worked our way back to agreement. I recommend the committee's report on older care, but 2011, and it's all in there. Rachel.
Very, very briefly, I think a quality service requires a quality workforce. Care is delivered between people delivering services and people receiving services, and the dynamic between them. It doesn't, for me, matter where you're delivering that service. We have members within the Royal College of Nursing that work across the independent, third and NHS sectors. And we would want to see fair terms and conditions for every single one of those. Like Lillian, we would support the living wage, and I was delighted that the principles for integration that were put through Parliament eventually contained a quality principle, and my hope is that as that is enacted by integration joint boards or by lead agents who are commissioning and procuring services, that thought of quality, that quality services require quality staff, will translate exactly into the procurement practices, which includes how they assume that the third sector or the independent sector will be able to fairly pay decent wages to their staff.
That we don't see a sustainable solution based on sweated labour and poor quality, but I think it all comes at a cost, and I suppose that's a challenge for all politicians about how we deliver this, and within that, getting back to a draft budget, which we've drifted off quite considerably, but and we're way by our time. Thanks for being with us today, staying beyond your allotted time and everything else. So thanks very much. We look forward to seeing our regulars again, and a special welcome to our newcomers today. Thanks very much for being with us. Thanks. I propose that agenda item number 4, which was a private discussion on health inequalities, be suspended to next week. Do I have the committee's agreement? Thank you very much. Thank you all.